Hello, everyone, and welcome to ID Ask Us Anything, episode 3. So excited! We have incredible people here with us today. Of course, the co-founders are all here. I'm Dr. Kathy Dooley, one of your co-founders. The amazing Dr. Folckomer is with us. Dr. Folckomer.
Hi there.
She's going to be very hot and ready to answer all of your anatomy questions. And then the incredible Danny Quirk, co-founder.
Hey, everyone.
And we have 2 special guests today from our teaching team in Toronto, Canada. We miss you, Canada. We hope that you guys let us back over sometime soon. And we have
hopefully sometime, yeah.
We have Lisa Burnfield, who you just heard giggle. Lisa, tell them about yourself.
I'm a physiotherapist. I also have a master's in anatomy because it's awesome. And yeah, I'm just excited to hang out tonight.
Oh, we're so glad to have you. Lisa has been a teaching team member for us, I guess, for a couple of years now.
Yeah.
And Dr. Monica Chadha, also team member from Toronto. Hello, Monica.
Hi, I'm Dr. Monica Chadha. I'm a chiropractor in Toronto, and thanks for having me here.
We're so glad you're here. And thank you to the amazing attendees that arrived tonight. We appreciate you asking your questions in the chat box below. You'll just use the share screen button to the left of that is the chat box. You just type in your question in the chat box and we will get it answered during this call. You may not have a question yet. Maybe something we talk about sparks a question. We want to make sure that your questions get answered. So one of the first questions that we had for the group is about the pelvic floor. And I believe that she's here. Jude. Hi, Jude. You had asked us about answering a question about pelvic floor or two. So you had asked about the pelvic floor's reactivity during breathing. And so I thought that we should do a screen share on that, and some pictures that we use in Immaculate Dissection, including some of our manual stuff. And so first off, before we do anything, we probably should just show people what the pelvic floor is, and then, you know, just calm some misconceptions about it, because I think there are several misconceptions about pelvic floor. And so this is the view from our manual, from our ID1 Core Concepts manual, where it's one of the 2 courses we cover pelvic floor, the other being ID6 Anatomy and Movement Subsystems. So these are the pelvic floor muscles, also called the pelvic diaphragm. And you have pubococcygeus, iliococcygeus. They attach to their pelvic parts, respective also to the tendinous arch of levator ani, which is fascia from obturator internus. And then coccygeus, a rather debated muscle, but also a part, the part that encapsulates the posterior aspect of the pelvic floor as it attaches to the coccyx and ischial spine. So these form the pelvic floor musculature that allows for containment of pelvic organs. It does have 2 major hiatuses. One's a urogenital hiatus, and one is, of course, the anal hiatus. And the pelvic floor muscles are considered to us in Immaculate Dissection and via Volleyman's work as intrinsic core muscles. And so let me stop the share screen on that and pull up our intrinsic core picture from our manual here. And this picture will show you the relationship between other intrinsic core muscles. And here we go. So in this picture, you can see the intrinsic core stability system is made of the thoracic diaphragm, which initiates all breathing through inhalation, the transverse abdominis, internal abdominal oblique, multifidus, and erectors. And then here's the pelvic floor, or the pelvic diaphragm at the bottom. From here on out, I'll just call it pelvic floor. So in a biped, the functions of the pelvic floor are numerous and actually sort of poorly understood because of the difficulty doing EMG in this region, right? And that's kind of the gold standard on neuromusculoskeletal is using electromyography, right? Very difficult to do in the pelvic floor, so it makes it a little bit of an elusive thing. Now, in a quadruped, the pelvic floor serves a little bit of a different function because it's helping to wag a tail, especially coccygeus, right? Also, the pelvic floor is used for defecation. It's used for sex, like it is in humans, but we're biped, so it serves an extra purpose in a biped to buttress the downward pressure of organs during the building of intra-abdominal pressure, which is us being able to inhale. So when you inhale, this thoracic diaphragm drops down, and of course the entire system will drop down, right? but this does not drop down as much as, like the pelvic floor doesn't match that drop down. In fact, we don't want it to. We don't want it to drop down as much as the diaphragm, because then we would start to extract contents out of our two major hiatuses. And that would be unwelcome and called prolapse. So these muscles, these pelvic floor muscles, are unlike the rest of the intrinsics at that they are vastly type 1A fibers, which is slow twitch, very hard to fatigue fibers. Now, all of these intrinsic muscles have a lot of type 1 fibers, but the pelvic floor has 70 to 80% type 1, which means cueing it to kind of pull in and contract all the time with something like a kegel may only work about 20% of the fibers, unless you plan to do about 1,000 kegels per day, right? Instead, the pelvic floor is reacting to the intrinsic abdominal stability system, which means it's reacting to what the diaphragm's doing, what the transverse abdominis is doing, what the internal abdominal oblique is doing, what the multifidus and erectors are doing. And by reacting, it participates in the breathing cycle. Sorry guys, you don't breathe with your anus, nor do you breathe with your urogenital diaphragm. You're not breathing with your pelvic floor. It participates in the breath cycle through the containment via the hiatuses. So I just want to solve that mystery, and let's stop calling the pelvic floor a breathing muscle, because it's not. It participates in intra-abdominal pressure containment. It helps to encourage the breathing cycle, but it is not a breathing muscle, no more than the adductors are. All right, so that said, the pelvic floor is intrinsic and is very important for making sure that we, as a biped, don't prolapse organs out through these holes, which means it's always under a bit of eccentric load in the quadruped, in the biped, rather than in the quadruped, where it can become a little bit more phasic and move the tail quite a bit. So when you're constantly cueing people to pull up their pelvic floor, be really careful with that cue, because you might have someone who has a tight pelvic floor because it has to be, because it's not reacting well to the intrinsic core stabilization system. And then when you cue someone to pull up, first of all, they may already be up and needs to be in a better position. Or if they're falling down, pulling up can alter that breath cycle of a good quality inhalation and containment. So that's where the kegel gets really debatable. That's why you're seeing all this research come out about in the recent years of, is the kegel the appropriate activity? And in immaculate dissection, we say that's not the best usage of your time. Like walking around with jade balls up the vagina may not be the best total therapy for someone going through a pelvic floor trauma, like childbirth, like episiotomy, like sexual trauma, like prostatectomy, vaginal surgery, rejuvenation, gender affirmation surgery. So in that litany of things, we have to understand that the kegel is a phasic cue and not a tonic one. And you better be doing a ton of repetitions if you really are going to be working the actual pelvic floor itself. And so you got to be really careful with that kegel. I can't remember the last time I assigned a kegel. So the quick answer to the question is ID theory is not really supportive of constant kegel usage. In fact, it's quite the opposite. We find that if pelvic floor therapy fails, which it has quite a high failure rate, then what we have people do is supplement their pelvic floor therapy with the training of intra-abdominal pressure and properly cueing the pelvic floor, and also proper femoral centration cues, which we teach in ID1 and ID2. Anna, do you want to talk a little bit more about this?
Yeah, sure. So in it's interesting because in ID1, Kathy and I get real up close and personal with our pelvic floor issues, which we're both, we've learned a lot about pelvic floor through our own issues. And what's so cool is that we present in similar ways, but our the pathomechanism behind them complete opposite. And so what that essentially shows you is that, if you just sort of applied a protocol to all pelvic floor issues, that could really create some issues, certainly just if you're in values 2, being Kathy and I, right? Because the thing that I need could aggravate her, and the thing that she needs could aggravate me. The other thing that's really interesting about this, Kathy talked about the reflexive nature, is that we assign sort of this flow chart of how to basically tackle the clinical problems in front of you through assessment in ID. And we don't start with pelvic floor. We don't even do pelvic floor right after breathing. We get to pelvic floor at the end of the, sort of the other, we have 3 other assessments in front of it. So it really starts to come at the end of the weekend for us. And the reason why is because of the reflexive nature of the pelvic floor, pelvic diaphragm being, so easily cued or miscued by all of the other structures. Yes, it does sort of help close that container. And if we're going to have a discussion about the building and release of intra-abdominal pressure, then you have to talk about what is actually enclosing this container. And the pelvic floor is certainly one of those things. And so it comes up in ID1 for that very reason. It comes up again in ID6 for that very reason. But the actual cueing of it, we don't even get to until we've cleared everything else. And then when we get to it, we talk about how, it's not a one size fits all. And everybody sort of needs, you have to still assess, and you don't get a pass just because, oh, well, there's, pain with sex, or, a little bit of leakage and stress incontinence, or trouble voiding, or, numbness and tingling, or whatever all of the symptoms can present. There's sort of a whole slew of them. You still have to go through the assessment process. And then the things that we tweak, it's not really to kegel or not to kegel. It's the intention. I love the sort of intention of holding, and then the intention of releasing is the closest thing that you'll really see us do to a kegel in ID. It's not just, and Kathy said it perfectly, you can't take something phasic like that and try to apply it to something that isn't a phasic structure. So, I think it's the other sort of clinical pearls that we find is that by the time we get to pelvic floor, we've experienced a little bit of what it feels like to be in quadruped, and we're sort of gathering some information because people with pelvic floor issues, it'll really start to become more pronounced when they're in quadruped. And by the time you get to it, sort of at the end of the day, there's already a lot of noise about it. So, there's so much information to gather. And I think that we would be sort of falling a little bit short, and it'd be a little self-limited if we only just sort of diagnose pelvic floor and then assign to kegel. Like, there's so much more to talk about there. There's so much more to expand upon there. And so we do our very best, just from having learned through our own pelvic floor issues, why that may not, necessarily meet the mark.
I have to agree with that 100%. And I also think that when people think they're doing a kegel, they're actually squeezing sphincters. I think that they're squeezing their external anal sphincter, which is pudendal nerve innervated. Only the fascia at the bottom of the pelvic floor is innervated by pudendal. Pudendal nerve is concerned with your genitalia. Pelvic floor is different than genitalia. Pelvic floor is intrinsic core stability muscle, right? It's trying to help you with force transfer and containment. And just to pull up a picture real quick, because I think that a picture speaks 1,000 words sometimes, and I want you guys just to see that the pelvic floor is not the same as the anal sphincter. And I know that I'm not trying to, point out the obvious, but sometimes you have to. Like, here's the vaginal opening, here's the urogenital hiatus, right? So there's the urethra, here's the vagina, right, for the female. Here's the external anal sphincter. Now, just take a second, if you're male or female, and do a kegel. Okay, and let me know if you can do this without squeezing your butthole, because that does take quite a bit of control, right? A lot of people, unless they've had pelvic floor therapy, which I have had, and I know Anna, you probably have, because we both had pelvic floor disorders. It's really hard it's hard to separate them. The whole point being that when most people are thinking that they're doing a kegel, they're activating any number of things through here. Gluteus maximus, here's levator ani, here's pelvic floor. You can even be doing the erectile tissue contractors, like here's superficial transverse perineum, ischiocavernosus, bulbospongiosis, adductors. I mean, there's a number of things that are around there that you're telling the body to cue. So it's not that we don't cue it, it's that, we try not to make that the prime focus. The prime focus is inhalation, exhalation, getting the pelvic floor the cue that it needs to be a tonic muscle so that it can support the down bearing upon it. It has to buttress against your down bearing pressure, just like when you jump on a trampoline. When you're jumping on a trampoline, you're really glad that it doesn't collapse on you, right? Same thing, pelvic floor. Pelvic floor is giving you a little bit of resistance as downward play is placed upon it. So yes, the entire thing comes down, but pelvic floor is maintaining a lot of its central position. And it like Anna said, it's not at all really, that phasic. Danny, do you want to piggyback on that?
I mean, just to kind of chime in and reiterate what was being said beforehand, but again, just making sure through doing series of assessments, just making sure that you're working on the right structure for the right reasons. If it ends up being pelvic floor ends up becoming an issue from trickle down and whatnot, a lot of those things could be fixed from working higher up the chain and whatnot. So
we totally do that. We have 4 assessments, like Anna had said, in ID1, 1, 2, 3, 4, and the 4th is pelvic floor. You have to do a litany of things before we'll even if the person comes to you and says they have a pelvic floor problem, we're not even going to be cueing that pelvic floor until, subsequent visits. And that requires a lot of education about, the fact that the pelvic floor is cued by things that are kind of higher up in the hierarchy, and you have to make sure that there's not a problem with those, or else you're going to be spending a lot of time. I had spent a lot of time getting internal releases, and it would feel good in the moment, like it would give me release, but it wouldn't stay. And it wasn't until I retrained the entirety of the intrinsic system along with pelvic floor to work together as a team that I got sustainable relief. And I don't do kegel as much anymore. I do the entirety of what we do in ID1, which is train the intrinsic system. And that's things like neurodevelopmental positions like supine 90-90, crocodile breathing, get-ups, are my prime, pelvic floor rehab. So Dr. Monica, do you want to piggyback on that?
Yes. Actually, what you just touched on, saying that going through the flow chart assessments 1 to 4 for ID core, until I took core, I was just like throwing darts in the dark with pelvic floor stuff. And it was, kegels, internal releases and whatnot. And like you said, nothing was really sustainable until training breath and going through the proper process. And sometimes, actually, even in my experience now with a lot of patients, we don't even get to assessment 4 and they're already experiencing huge changes that are lasting for a very long time. So just to kind of piggyback off of what you were saying.
I love that you said that too, because I think that what I was misconstrued about as a pelvic floor patient is that my therapist had told me, pull up on your pelvic floor before you breathe in. And, I was a chiropractic student at the time, so I was kind of like, wait a minute, is that right? And they're like, yeah, your pelvic floor, you're leaking and stuff, and, you feel like you have to pee all the time, but you really don't have to pee. So you pull up and then breathe in. And I'm like, wait a minute, but the whole system is supposed to come down a little bit. The pelvic floor should buttress up against it, but I don't think I should be physically cueing it to go up, because then that's going to false cue everything above it to fire. And so when that pelvic floor, especially pupil coccygeus, is attached to the back of the pubic body, and you've got transverse abdominis, internal abdominal oblique, even rectus and EAO right there at the pubic crest and pubic tubercle respectively, they're ready to cue the pelvic floor to go into action. They're waiting with literal breath that's bated to react to those 4 larger muscles that have massive attachments to the pelvis and also attached to ribs. So you can't be a breathing muscle if you don't attach to ribs. And if you are going to participate in breathing, you better wait for a good cue, a quality cue from the things that are proximal to you. And that's what we focus on in ID, is not making pelvic floor symptoms a primary pelvic floor problem. They can be a part of a system of problems with the intrinsics. How about you, Lisa? I can't unmute you for some reason. There you go.
Yeah, I think for me, you kind of touched on it briefly, but it's that imagery of the trampoline that always really helps me understand how it works. So it's understanding that it has that level of tension that's just sort of always there, and then it just kind of that pressure down is that like that someone jumping on a trampoline. That always really helps me to visualize and understand what it does. And then aside from that, I think there seem to be certain things, I think as practitioners, a lot of us sort of almost, it's like, oh gosh, someone has this, it kind of freaks you out. And you just still follow the same procedure you would follow? And it's all about figuring out why something is tight. Like, you can't just go releasing things or activating things that we don't know why. So we still have to go through our assessment process and work through the steps, step by step, to figure out what's going on, why it's happening, and how we're going to address it. So I think it's just kind of working through that regardless of what it is.
That was huge. Like the fact that you don't get distracted by the symptom, and you appreciate and respect the symptom by following a standard operating system and a flow chart. And so I'm really glad that you mentioned that, Lisa, because in ID we have the saying, like, where do I start? At the flow chart. And you just kind of say it as a mantra. That way you don't get stuck on getting confused about your client, that you have a standard operating system and you know, that you can rely on an order and a hierarchy. Awesome. And not to say that all those things are bad. We're not trying to poo-poo pelvic floor therapy. It like anything, it has its limitations, right? It has a high failure rate. Why do you think it does? Because it on its own may need to be supplemented with something like ID, to where you can get rid of why the pelvic floor is tight all the time. Some of my patients, they really rely on their pelvic floor therapist in this beautiful way. Like they're like, oh, the only thing that gives me a moment of relief. And I'm like, then do it, but also understand why something's tight, like Lisa said. So it doesn't mean that just because you go to your pelvic floor therapist doesn't mean you get a pass on building intrinsic core stability. You have to do it, or else your pelvic floor is going to remain tight, and you're going to keep that pelvic floor therapist even busier than he or she has to be, right? Just, you know, you can supplement and actually complement, you know, your pelvic floor therapy with good intrinsic core strategies. So Jude, well, hopefully that answered your question. If you had a specific piece that didn't get answered, let us know in the chat box and we'll make sure it gets covered. But I think that was, you know, very helpful from the ID team. Thank you so much for all your wonderful statements. We have a question from Gurinder. No surprise, he asked the best questions. And so let me read it to you folks. Gurinder's current understanding is that rehabilitation on a flat, stable surface is mostly proprioceptive training. And when that shifts to uneven or unstable surfaces, it becomes mostly vestibular training. Yeah. And then he asked the difference of why is it shut down so much? Why does the system shut down, the proprioceptive system? You cannot separate the proprioceptive system from the vestibular system like that. Okay, so there's 3 components of equilibrium, right? 3. And you need 2 of them to be functioning together and synergistically at any given moment for you to be able to maintain this thing we call equilibrium or balance, right? And here are the systems. Eye movement system. This is cranial nerve 3, 4, and 6 with the vestibular ocular system, right? Then we have the proprioceptive system, which is incoming position sensing, right? And this is mostly cerebellar mediated, right? Now we have the vestibular apparatus. The vestibular apparatus are the 3 sets of basically lymphatic canals. They're perilymph and endolymph. And there's these ductile systems that sit in your inner ear adjacent to your cochlea that they basically react when you tilt your head. So it's mostly head mediated, and because your head's connected to your feet, according to peer review literature, when your head moves, your feet change, right? So that's the vestibular system based upon head movement, which can also include the foot movement that Gurinder's talking about. Just because the foot moves doesn't mean the head doesn't. It absolutely does. When your foot moves, your head moves. When your head moves, your foot moves. It's not under debate. They've seen that in the research many, many times. So you can't really say, hey, I'm on a stable surface, but I'm not working the vestibular system. And hey, I'm on a Bosu ball, and now I'm working the vestibular. It doesn't work that way, right? Now, why we start people on a stable surface is to work all 3 of those systems, right? Because most of the time you're on a relatively stable surface. The hardwood in your house, the carpet in your house, the relative sidewalks based upon the fact that most of them do not change their position while you're on them, right? You might change relative to that position when you fall on a crack or something, but for the most part, the surface is relatively stable, right? And then you put someone on Bosu, right, is what we're talking about, the unstable surfaces where everything's changing. That is causing a reaction in the system by taking away your surface of ground force contact that's going up to change the canals for sure, but it's also changing eye movement. It's also changing proprioception. So you can't like rule out one and say, hey, I'm only working vestibular and I'm only working, it does not work that way, right? And what's so, shall I say, fantastic about people that are really good on uneven surfaces, right? You see people do crazy stuff like, you've seen those gym videos where people like squat on a Bosu ball and stuff, and they do amazing things on it, right? They've trained eye movement, proprioception, vestibular. 2 of those 3 have to be working at any given moment for you to be okay. Like you can't have this gigantic set of semicircular canals in your vestibular system and, you know, and then not have trained proprioception, because the systems are feedbacks into each other, and you have to have 2 of those 3 systems working at any given moment for you to feel balanced, right? So the reason why we encourage people to be on a stable surface when you're initiating training is that it takes out the extra variable of your surface change, right? So if someone cannot stabilize on the ground, why in the world would I put them on a Bosu ball? I mean, a lot of my patients, if I try to put them on a single leg, they're wobbling all over the place. I don't have to put them on a ball. And putting them on a ball to stabilize doesn't necessarily make everything better when they come off the ball. I just changed the variable, right? So it's very smart, we think, in ID to use a stable surface and get stable there first before you start altering the surface underneath, because they're going to have to constantly react to any foot changes that cause a mediated kinetic chain relationship through those 5 subsystems we talk about in ID6 up to the semicircular canals, eye movement, and proprioceptive channels, right? Anna, do you want to piggyback on that? Oops, sorry, I'm trying to unmute you.
Yeah, that's okay. Yeah. It's such a fun question, right? And yeah, I love what you said about, you know, there has to be this sort of internal harmony of you really can't sort of take away one without the other, because when you're talking about these sort of like 6th and 7th senses, you're talking about your body's ability to collect information from the external environment around it and orient accordingly. But then you're also talking about the vestibular system being sort of like that internal GPS system of how you're navigating that. And not only if you're moving, but if you're not moving, right? So just because, like, you know, like Kathy said, maybe you're not on some sort of balance board or a Bosu ball or something, your vestibular system is still equally working to tell you that you're not on that thing. So there's, you have to have, you're never going to really isolate one without the other. And you know, in ID4, we include really focus on eye movement and the eyes preceding some of the neck movement and the head movement. And, you know, we give all the clinical reasons behind that. And it's because we can't, you know, we're these really intelligently put together beings. You can't just sort of take one element of ourselves out, extract it, work on it, perfect it, and then like put it back in. Right. And so just like Kathy's saying, with the ability to kind of get it as simplified as possible and eliminate some of these excessive perturbations, excessive variables, and perfecting the system there, and then gradually starting to kind of push it and stress it a little bit more to just see how it responds. But as you were talking, I was thinking about when we were in Hong Kong last year, and you probably know what I'm going to say, Kathy. So Kathy and we love to collect our data. Like we have at this point, like we've got fun relationships with our symptoms. It's kind of like, yes, I got a symptom, I got to learn about it, I got to see what's going on. And so it makes this, like, you know, approaching something with clinical curiosity is a lot of fun, and it changes your relationship to pain management and all that stuff. So whenever we have symptoms, we're like, oh my God, that's so cool, my body's doing its thing. So we had we do our supine 90-90s, and I know my tendencies and she knows her tendencies, and, you know, they're there, and we know when they're loud, and, you know, if we're stressed or tired or jet lagged or, you know, slept like this or something, they all come out. And when we were in Hong Kong last year, we did our supine 90-90s on a slack line. And what we found is that while it was infinitely harder and there was some really interesting information to gather there, we were still able to gather essentially the same information on that slack line as we do when we're on solid ground. And all of our tendencies were still there. Like, you know, my ability, you know, my inability to kind of externally rotate my right femur, and, you know, my tendency to kind of like hyperextend at some point, like the way that I was organizing myself was exactly what happens when I'm stressed in a less stressful environment. So it didn't necessarily give us any new information. It was just sort of progressed to a certain point. And why start there? You know, if I'm going to put my patient through supine 90-90, it ain't going to be on that slack line.
Let me tell you what, supine 90-90 on a slack line is
It's
not
hard enough.
Yeah, so it reminded me, I'm so glad that you brought that up, because it was literally in my mind, like slack line, right? It, and you know, having come home, I do supine 90-90 every single day, multiple times a day. I really love that activity. And but I don't, you know, get on my slack line every single day to do supine 90-90, although it's very fun. I think that, you know, I get more feedback, like Anna's talking about, making the variables as simple as possible, and then stabilizing it, and then making it harder, then making, you know, the challenge go up.
Yeah.
And I think that, you know, life's hard enough. Why throw a BOSU ball at it? Make it, you know, like you can do it, get good at it, and then move to something like a slackline, or move to something like a BOSU if you want to add extra challenges. But for my patients that need balance, like at Catalyst, we have one of like the Grey Cook, like long orange 4-inch beams, kind of like, you know, what you would use on a balance beam training for a gymnast, right? And they have incredible proprioception, vestibular apparatus, eye movements. They're pound for pound the best athletes on the planet, right? Why don't they train on BOSU? They don't, by the way. I can validate that. The vast majority of them don't. So they train on their equipment where it's the most stable, and then they react to the system, right? So and you watch people that are trying to wake up their brain, you know, a really good way to do it is walking tandem line. Like walking, it doesn't have to be an altered surface for you to get a massive amount of vestibular system information. And then you work your way up to something that's harder. Danny, you want to piggyback on that?
Just along the lines of, again, like just wanting to build that, build the most amount of stability from a stable platform at first, and then, you know, from there you can really kind of see everything at its most common and basic element from there, and then being able to move safely forward or whatnot to build more of that strength that was lacking initially.
Monica, do you work with a lot of vestibular patients?
Not yet. I feel like it's coming up though. I have had a lot of people start to ask questions about it. So this is an area of interest that's peaking for me. But you guys did a really great job of covering that. My only add to it is the concept that, similar to the flow chart, you can't really jump far ahead and not expect to break down and see what you skipped. So I think it ends up being an assessment in itself if you've gone too fast, too far.
Yeah, I don't know. Like, I'm not going to spend all of my day training my breathing on a slack line, but I am going to spend my day doing it when I'm standing on a flat surface, because that's where I'm going to spend most of my time. And there is value in training on something that's more difficult, 100% more value. I do understand that. It's just, you know, you have to think about my patient. It's hard enough to get my patients to do anything, you know, for themselves. Maybe not right now as much, but like, you know, if I can give them 3 exercises, you know, getting them to commit to that, you know, once or twice a day is a big commitment anyway. I want the most bang for my buck, and maybe get them stable on the ground first and then move them up to something that's harder. My 87-year-old patient, was his previous trainer had him on a BOSU, which I found fascinating. And he's like, I think it helps my ankle. I was like, that's awesome. And then I put him on flat ground and asked him to walk in tandem, and he was all over the place. And I was like, that's my point, that we have to clean up the discrepancies in the proprioceptive system, which for us can be pendulums and moving through space and eye movement focus. And then the vestibular system has its complications with the perilymph and endolymph and calcium and, you know, potassium and sodium and stuff. But all in all, if I have the other 2, I don't need the other one. You know, I have to have the other 2 as strong as possible. And I'm not so sure it needs to be on a wobbly surface at first. Lisa, you want to add any more to that? You're a physical therapist. Help us out.
Yeah, I think it just, for me, it's more just like, why add more variables and more noise to the system? When we're assessing people, like, let's just keep it as basic as possible, because often you're going to see stuff in those areas that need to be fixed. And if we add another thing, it's just, there's too much noise, and it gets harder to see what the real kind of primary issues are. And then also, I see huge benefit and improvement after working through like some of the other things, when we work on like the breathing and like actually work through the flow charts, as they're meant to be worked through. A lot of times that clears up a lot of stuff for people. And then you don't necessarily need to go to those levels, because that may clear up the issue.
Can I share a story where I just literally bit it? It was, I know the ID team remembers this because it was right before we went to Asia last year. And I had a very bad fall down some stairs, right? I mean, I'm a klutz. I am working on it, right, with my ID stuff. But I was excited about some takeout, and I was a little bit naked, and I was wet, and I slipped on the top stair, and then I came down. I mean, there's that moment you're like, oh, this is not good, right? And then I came down, and I fell in a way that was very much like the elbow prop of the get up, because I had done thousands of get-ups. I trained a proprioceptive pattern that was going to be load shared and safe for me, right? So that I was able to go to it when I needed to. And then I came out of it with nothing really wrong other than some just really ugly bruises accompanying me to Asia, right? But I had no concussion. I had no serious, I had no fractures. I had nothing wrong with me, right? Really, it was about me training the proprioceptive system to be able to handle when something did go wrong. My variables did change. My foot could not contact, and it slipped. And then I was able to orient myself because I had trained it thousands of times. And that's what I think is so important about when someone has a proprioceptive vestibular issue, is that you can train them to react better to the environment, even if it does change. But it doesn't necessarily have to be on something that is constantly changing variables all the time. Like, I've never done a get up on a Bosu ball, nor will I ever. The slackline would be interesting, but I don't intend to be training most of my get ups on a slackline, because I'm training on the ground, and then I'm going to react to my environment, and I'm going to have a system of proprioception that, and a remembering of that event, a limbic event. I'm going to remember that happened because I've trained it. So there's a huge thing to be said for training things on stable ground as much as possible, and then throwing in fun variables as extras if you are so inclined. I think that we covered that major question. And Gurinder, let us know if there was a piece of that we didn't cover. And we're not really getting a lot of questions from you guys. We would really like some. So remember that the chat box is down at the very bottom. If you look at where it says share screen, there is a green share screen. Go to the left of that and it says chat. And so type in a question if you'd like us to answer one. Otherwise, we're going to talk about what we want to talk about. And then I'm just going to open up the teaching team members things. We did want to talk about one thing while you're thinking of questions. So teaching team, you're all on except Lisa. There we go. Lisa, I can't unmute you for some reason. There we go. So we wanted to announce that you guys have inspired us so much with the ID Ask Us Anything that we are going to be starting something really soon that we're going to be announcing to you guys, where we're going to be taking all of the topics that you guys are interested in. You just message us, and we're going to be creating hour-long lectures about them. So we've already gotten fun, questions about gait and breathing and thoracic outlet syndrome and pelvic floor issues. And we're going to be collecting all of these, and we're going to have like an ID collective where, we can, give you these, opportunities to listen to lectures and play them back on, great topics. And we're just going to do a little bit more prep, in advance to be able to give you all the things that you need to be able to be successful in the lecture. So we have more to announce to that soon. So we're so excited to be baiting you with that. But you guys are helping us kind of do test runs on what you guys want. And we're really excited to be fielding your questions and figuring out, because we know what we want. We don't necessarily know what you guys want. So as our idealists in the making, we really want to know. So if you have questions, go to the box, or if you wave at me at the bottom, I can open up your camera, but we prefer you use the chat box. And Jude is asking for a neuroanatomy ID course. Well, we already have one. It's called ID5. ID5 is peripheral nerve entrapments, and we cover all the basics of neuroanatomy in that course. So we cover general somatic afferents, efferents, special visceral, special somatic afferents, efferents. We cover all the major axons. We cover how to treat that in your clinical practice. We don't cover CNS disorders in that, but we cover peripheral nerve entrapment covers a lot of ground. And so maybe get started with that first, and then we'll talk. I used to teach neuroanatomy, so I feel pretty confident about that topic, and I'm sure that we can ask you guys how you want to do that, how you want to make it applicable to you. But we're not going to have any more ID courses. Just to let you know, we're done. It's ID 1, 2, 3, 4, 5, 6. But we will do in the collective, right? Which, you know, name to be determined. It may be Ask Us Anything. But what we'll do is we'll hit topics that you guys want. So, dude, if you want us to talk about neuroanatomy of this particular topic, we can cover it for you. That's the cool thing about having a collective. We ask you guys what you want, and then we study up and apply our concepts to things and give you the information in the ID lens.
Yeah.
So,
yeah, I mean, and we get that, you know, different people have different interests, and you know, sometimes they're sports specific, sometimes they're patient population specific. You know, we've had a fair amount of attendees that work primarily with children, or with wheelchair bound populations, or with you know, pre and postpartum patients. And so we wanted to open up an opportunity to give you guys a chance to have that really sort of like narrow down, and you know, because it comes up anyways, and that's what's so fun about teaching is we've taught all these classes, I don't know how many times now for the past 6 years, and every class is different. And you know, and for all those people that are like, is this going to be on the Vimeos? Like, now we're going to have a place to put that for you, which is, you know, Jude, if there's a question about a specific topic within neuroanatomy that's not already addressed by ID5, but, you know, you want to talk about stroke assessment or something like that, like we can deliver that information to you, and we want to make sure that we're doing it, you know, in a way that's not tangential to the other ID6 classes, and it's something that we can really just hone in on our focus on and attention and talk about in this really comprehensive way for you guys. So we're excited about this project for sure.
totally. That's the future, Jude. But in the present, the ID5 course is so much fun.
Yes.
We teach you how to differentiate between organ referral, pain, sclerotome referral. We give you little dances to do so you can memorize stuff, myotomes versus dermatomes versus peripheral nerve distributions, how to test them, and how to do everything in 2 minutes. You know, like how to do things quickly because you don't have all the time in the world to be going over with your patient all the neuroanatomy that you just learned. And we want to make things digestible. So if we don't cover it in ID5, we would highly suggest, if you're interested in neuroanatomy, take ID5. It's a very fun course, we think. We're very biased, obviously, but we think it came together well. And well, Monica and Lisa, you've not taught that course. You actually took it. Maybe you guys can talk about it.
Yeah, I found it incredibly helpful for clients who had any sort of neurological symptoms, just to be able to tease out what was going on really quickly. I had clients who, like, their perception of where they felt their altered sensation was nowhere near where it was actually coming from when we actually went through the testing for the neuro exam, which was great because it actually really cleared up where the source was, so how we should address it. Yeah, I found it incredibly beneficial, and it's, you know, you do it in 20 minutes, like max, you know, so that's always a good thing, right?
Totally. And Lisa, and you and Monica both are trained manual therapists in Canada. You guys were already kind of versed in some neuro, right? Monica, what did you get out of it that you either got repeated for you from chiropractic school, or what did you get out of it that helped you enhance your treatment of your patients?
2 things. Nerve flossing. I didn't get to learn a lot of that in chiropractic college. We kind of did like a teaser course, and then that was it, and it wasn't a focus point. And then sclerotomes was a big one for me. I found those to be amazing new pieces of information, or new to me, which I was able to implement into practice right away. and was super helpful because it was those cases that I was just like, I don't know what's going on. What am I missing? And that's what I was missing. So
Oh,
very
right
helpful.
on. That's awesome.
Yeah.
Good. Looks like we had some time for a question from the gallery. How do you work better with patients with MS, multiple sclerosis, severe COPD, Parkinson's? Okay, those are very different disorders. So how would I work differently? Not differently at all. That is the point, is that you start thinking that people are different because of their condition. When it comes to immaculate dissection and biomechanics, you're in trouble because now you're trying to single out people thinking that anyone gets a pass. And whether they have MS, whether they have COPD, whether they have whatever disorder, Alzheimer's, no one gets a pass. You have to reiterate the concepts of each of our courses. And I think that honestly is very welcome from these patients who are often talked about like they're not a person, but a disease progression. One of our amazing attendees in San Francisco, she's become a dear friend of mine, and I'm sure she would not mind me sharing that she has MS, progressive MS. Her name is Kate. She is incredibly open, about the fact that she has MS. She's not a diagnosis. She loved the fact that, in the midst of the assessment, she was putting a cold pack on, the back of her neck because it really helped her keeping her, temperature down and her breathing relaxed and her anxiety down. And then she would prop up her elbows because it gave her more stability. Or we would accommodate her in those kinds of ways. But she knew she was not going to get a pass. She was going to have to go through the corrective strategies. I may have to modify her position based upon what makes her successful, but also being tough on her in a way that needed to happen because her neurological system needs constant stimulation, and she needs to rest when she needs to rest, but she also needs the stimulation. Same thing with Parkinson's. I tell my Parkinson's patients, make sure that you take your medications before you come because we're going to be doing some demanding stuff. And when you start to feel your medications wearing off, then may not be a good time to do your corrective strategies because it's harder for you to initiate the motions. But other than that, they don't get a pass either. They know it. They know that one of my patients is 84-year-old man with Parkinson's, and his son brings him in, and we have a great experience. It's wonderful. And he knows I'm going to be tough on him because in a beautiful way, that tough love kind of way, that the only way to help you sometimes is helping you through. And not catering too much to the fact that, I'm not going to pussyfoot around somebody. I'm going to definitely encourage them to get moving. With COPD, I just know that, gas exchange is an issue. So we may have to limit the total amount of reps we do at one consistent period. But again, it's an obstructive pulmonary disorder, which means if I don't push this person to train their breathing, then their condition progressively gets worse. So, meet people where they are. Take them where they're not. That's the ID motto. Got to meet people where they are. You can't just shove people onto the slack line when they don't have balance on the floor, right? Same thing here. Like when it comes to condition-based, I'm not so sure that the specificities change that much. Anna, you're a doctor at acupuncture and oriental medicine. You must see the gamut of diagnoses. Can you tell us how, what you would answer this question, how you would do that?
Well, one of the really cool things, particularly, with acupuncture, the diagnostic lens that you use with traditional medicine is one where you start to learn how to kind of have deaf ears on what a person comes in with. Not that you don't care, but you start to focus, you shift your focus to other things. You shift your focus on your assessment, whether it's Chinese medicine in combination with, of course, immaculate dissection and things like that. But what it really sort of trained me to do is it invited all of these different types of people into my office, and it opened the door to a lot of different types of conditions. And then it allowed me to approach all of them in the exact same way, and then learn what, these people, some of this stuff is not things that people were born with, right? So some of these things are progressive and later onset. They still are bringing their old strategies that have gotten them through life up until the point of their diagnosis into their diagnosis and beyond. And so just like Kathy said, they're not defined by their diagnosis. Everybody strategizes. Everybody has their own sort of narrative, subjectively and objectively, that we can learn from and observe and then still optimize. And it's nice when you have some sort of measures to be able to approach somebody in that way of like, all right, well, let's see what does normal look like for you? how can we make your, your presentation as optimal as possible? And, I can see Leah's questions in the chat box as well, and talking about, well, this person, elderly patients, or these types of cases, and you just meet them where they are. You can't apply this generic universal idea of normal to people and expect them to meet you there. You can see where they already are, and then you can try to take them and progress them accordingly. So, these are really interesting parts of their stories, and it does help to have some background information. This is why we have health history forms that are pages and pages and pages long, so that we can understand what somebody's coming to us with, but it doesn't really ultimately change their outcome that much in terms of how, the treatment that they're going to get in our offices.
Sorry. She also mentioned the fact that what if they have limited mobility? What if they're, weak? We don't do manual muscle testing as part of our strategy in immaculate dissection, but muscle testing would fall under special tests on our assessment list. So if you walk in with that knowledge, it's a wonderful addition. But do I muscle test change? No, it would just, I always muscle test light, but I don't do Kendall and Kendall grading unless I need to for a neurological exam. But, I don't really, I don't, I change very, very little. My patience is relatively the same. My focus is relatively the same. I think that they need that more than they need someone saying, hey, Parkinson's patient, I'm going to treat you differently because you have Parkinson's. I think that when you take off of that hat and say, look, this is what you need, and we're going to make sure that you get it, the results come faster. And with pendulums, when someone has a decreased mobility, just like if they had a total hip replacement or if they had Parkinson's, I would say I would meet them where they're at and take them where they're not. What can we get you done today? It's not like I need them to do the splits tomorrow if they have limited mobility. Probably shouldn't be doing the splits anyway. What I would do instead is just try to encourage stability motor control, which frees up mobility. And that would be true for any person with any diagnosis. We stand pretty firm on that statement that no one gets a pass. We say it at every seminar, and we say it over and over. Lisa, can you unmute you here?
I think, and this is something I've heard you say a lot of times too, is also like break things apart. Don't feel like you have to achieve, a whole thing in the first session. You can break it apart into lots, and this applies to everyone. It doesn't matter if it's a client with Parkinson's or a client with an ankle sprain. You have to meet them at their capabilities. So don't feel like you have to give them an entire movement that includes 3 things if they're not able to do it. Maybe they only get part of a pendulum for that session until they're really capable of being able to do the full pendulum. So I think it's also not rushing our clients. I think we want the best for them, and we want them to achieve it so fast sometimes that we're like, oh, I'll give you, 1, 2, 3, 4, and 5 all at once. And really they're stuck on 0.5. And if we just worked on 0.5, they'd actually probably progress faster.
Yep, that's the truth. Monica, do you want to share on this topic?
I think you guys covered quite a bit.
Okay,
awesome. I'm satisfied.
I'm just making sure. How about you, Danny? Oh wait, sorry, Danny, I accidentally muted you. There you go.
Oh, you're good. No worries. No, but yeah, again, like it's just all about that build up and whatnot. You don't like, you just want to start slower, start smaller, especially with patients who are coming through with compromises to start off with and whatnot. But again, like you're in essence working the same anatomy, you're working the same structure, so they're going to be treated in a similar setup. So again, like you just start with what they can handle, build, progress from there, just to make sure that you're moving on a stable platform and not creating future compromise.
I love that one of our idealists, she worked with a lot of CNS patients. So people with a lot of stroke, cerebral palsy, and she would talk about the fact that they couldn't walk, they couldn't sit up. So she would have them doing pendulums laying down in their bed. Or if they were wheelchair bound, she would have them doing pendulums in their wheelchair. I was like, that's called meeting people where they're at. That's crusher. That is the coolest thing I heard like that whole year. Like that's meeting somebody where they're at. And when it comes to like, if somebody walked into my office, they're not getting too much of a pass. If you walk in, you're probably doing pretty close to the same things that you're going to be doing for anybody else on that flow chart. And that's what you got to remember, is that don't make people about a condition. If your job is biomechanics, therapy, rehabilitation, Keep focused. Keep your eye on the ball. Anything else? I think that we got everything. Did I miss anything? Martha's question's a little bit more ID centric. She wants to see more case studies. But
Martha, I'm gonna plug those telehealth sessions for a second. The study groups that, you know, in the respective ID courses that you've taken, you'll see the telehealth study groups, and so many people are using the telehealth as a mode of communication with their patients and an assessment right now, and those are really great to get your hands on something like right this second of how to see something that is pretty full picture of, like, somebody's coming to me with a story and it's up to me to put them through my assessment process to figure out, you know, why that is, and figuring out the why. Like, we love the why in immaculate dissection. So so yeah, if you're hungry for something right this second, those telehealth study group sessions that are available to people who have taken certain ID courses at this point are phenomenal for exactly that.
for people who don't know what that is, like, we did these 4 study groups on how do you do ID assessments for telehealth. And ID is very hands-off anyway, other than the fact that we palpate to find some dysfunction. So we have to walk the patient through their own palpation. And knowing the patient doesn't have a lot of palpation skills, at least they have awareness skills of where their key complaints are. So what we like about ID is that it's mostly hands-off, so that you can educate the person on how to assess themselves and how to correct themselves over time, which is a really good bonus piece of ID. And it, for me, it's like, my patients are like, I had several patients today and they were like, wow, this isn't really all that different than our session in person, other than the fact I can't give you a big hug, Dooley. And I was like, that's the idea, is that no matter if we have to do telehealth or in person, I should be able to help you help yourself. And the telehealth things do that. I think that what made it so popular is that they get to see me using the process start to finish. But I think you only really need to see that once, right? And there's several, for each of the IDs, there's several case studies under extra material, but watching me do it is not going to really help past seeing it once. Because then you're just going to start parroting what I did. You need to go through it once, watch me go through it once, understand how a flow would go, and then you need to actually do it yourself. You have to do it yourself. ID was created out of these 3 people in the top left corner doing it for themselves, right? And so we have to, at some point, we have to bite the bullet and say, wow, cool, solve some case studies. Now I'm going to attack this and apply it to my patients with my standard operating system, my flow chart, and my assessment checklist.
Yeah, for all the reasons. Oh, sorry.
You go.
Well, for all of the reasons that we just talked about, like, you don't need to see a clinical case study of, you know, somebody with greater trochanteric bursitis or something, like, because you would still be approaching them the exact same way as you would anybody that comes in with, you know, the ID2 stuff. I'm sorry, the ID1 stuff and then the ID2 stuff and all that stuff. So, yeah, for all the reasons why, I mean, we don't want people to get in the habit of confirmation bias, obviously. So once you see how, you know, we write out the flow charts and they're in all of the immaculate dissection individual groups on Facebook. And once you have that flow chart and you just need to see a really great example of how somebody puts that to use in real time, there's your template. And then you can, you know, it's like Mad Libs at that point. Like, you just fill it in with different conditions and different stories and different people and different backgrounds and different places and on the internet or not on the internet and in your office and wherever. You get it.
I love it. If you really want a good study yourself and hire Monica, Lisa, Anna, myself, hire an ID person to analyze you, or partner up as a study buddy with someone that has taken ID, and then you can really learn how to create a flow with it, right? Okay, so it looks like it's the end. We have to give out a $50 coupon. Okay, so I hope you guys are ready. Now remember, your chat box is at the bottom of this, to the left of the share screen in green. Okay, the first person to correctly answer this question: are you ready with your QWERTY? Are you ready with your voice dictation? Get ready, because I gave you the answer to this question earlier. So if you were on the ball, here we go. Name the 3 systems that help us with equilibrium. Go. You win $50 off an online course or in-person course. Yes, Gurinder, nice. Gurinder, vestibular, proprioceptive, and visual. Excellent. That was fast. Holy cow. I think he even corrected his, I know, right? Boom is right. So, Grinder, Anna in the chat box gave you the email address for Immaculate Dissection, immaculatedissection@gmail.com. You get $50 off an online course. For $50 US, by the way. Woo-hoo! So you'll get an online course for $250 US, which is a steal, an absolute steal. We hope you enjoy your first course with us. So folks, we would love to see you again next Sunday. We hope that you guys tune in. Please bring your questions. They were so great. And a huge thanks to the co-founders. Love you guys to pieces. You make my Sunday so much fun. It's just a blast.
Love you, Kathy Dooley.
And
Thanks to
yes, hugs from afar, virtual hugs. And Monica, Lisa, you are phenomenal. We really we're going to try to coerce you into coming every Sunday if you can. At least while we're all under lockdown. We appreciate you so much for taking the time out to be with us.
Absolutely. It's always fun, right? And it's great to always hear, you know, other people talk and how they approach things and their thoughts and stuff. And I think we always have an opportunity to learn. So
We love hearing you talk. If you guys have not seen her press video on our Instagram, you should watch it. It's so good. And Monica made a killer quadruped alternate video that she got so many compliments on too. So we hope that we can hook these guys into coming next Sunday if they're not too busy. So thank you, folks. Future idealists out in the crowd and current idealists, thank you so much for coming onto the ID Ask Us Anything episode 3. If you missed the first 2 episodes, they are on YouTube. We have them posted on our Immaculate Dissection Facebook page as well. So I will upload this now to YouTube and I'll post it in the next 24 hours onto the Immaculate Dissection Facebook page. So make sure you follow us there and you may see your amazing questions answered right here on the show. So thank you folks so much and we hope to see you next Sunday.
Thank you, guys.
Bye.
Bye.